Irritable bowel syndrome increases paracellular permeability, leading to the entry of pathogens and toxins into the colonic mucosa, the activation of immunocytes, and the release of pro-inflammatory cytokines that sensitize sensitive motor nerve endings, resulting in hyperalgesia. IBS is a functional bowel disorder in which recurrent abdominal pain is associated with transit disorders and abdominal bloating. Our solution for tackling intestinal pain and bloating is meteospasmil. Simethicone lines the colonic wall, providing a protective barrier that decreases intestinal paracellular permeability, limiting penetration by toxins and pathogens. It also modifies the surface tension of gas bubbles, facilitating their evacuation. Alvarin is a musculotropic antispasmodic that works by blocking the calcium channels of the smooth muscle cells of the wall and relieving spasming. Alvarin also has an anti-nociceptive action. It decreases the excitability of the wall's mechanoreceptors and therefore the transmission of pain messages. Through its selective antagonism of 5-HT1A postsynaptic receptors, Alvarin specifically inhibits the excitability of afferent neurons and the transmission of pain signals, producing an anti-nociceptive effect. Irritable bowel syndrome increases paracellular permeability, leading to the entry of pathogens and toxins into the colonic mucosa, the activation of immunocytes, and the release of pro-inflammatory cytokines that sensitize sensitive motor nerve endings, resulting in hyperalgesia. IBS is a functional bowel disorder in which recurrent abdominal pain is associated with transit disorders and abdominal bloating. Our solution for tackling intestinal pain and bloating is meteospasmil. Simethicone lines the colonic wall, providing a protective barrier that decreases intestinal paracellular permeability, limiting penetration by toxins and pathogens. It also modifies the surface tension of gas bubbles, facilitating their evacuation. Alvarin is a musculotropic antispasmodic that works by blocking the calcium channels of the smooth muscle cells of the wall and relieving spasming. Alvarin also has an anti-nociceptive action. It decreases the excitability of the wall's mechanoreceptors and therefore the transmission of pain messages. Through its selective antagonism of 5-HT1A postsynaptic receptors, Alvarin specifically inhibits the excitability of afferent neurons and the transmission of pain signals, producing an anti-nociceptive effect.
Hi, good afternoon, everyone. Afternoon. I can slowly have a seat. Today is the most hybrid of events. I've never attended a CME or webinar or class as hybrid as today. You can take your time and have a seat. I explain why. So, all right. Okay. So, good afternoon. I'm Dr. Linges. I'm a general practitioner with the Medivam Group. I'm also a healthcare speaker and a financial literacy advocate. I speak at these kind of events. And today, EP Plus was very eager to invite me to chair this event as well, because it's a medicine I feel has a lot of potential. But first off, thank you so much to EP Plus for inviting me and also our esteemed speakers. Thank you everyone here and at home, especially those who took the time to come all the way here. Yes, and we have a large number of doctors and pharmacists online. I think we're hitting about 400 plus packs online. So it's quite a big event actually for today. So now, why do I mean today is the most hybrid of hybrid? We don't just have everyone here, and we don't just have people online and live streaming there. We also have later on one of our speakers is currently in the UK, but he will not give up the opportunity to speak for this. So he is going to be streaming the video. So we have a video for his third item today, and as well as a live Q&A all the way from UK. As for our second speaker, he is literally on the way from the airport right now, being rushed over by our staff as well. So that's how hybrid today is going. So anyway, today it's an IBS Masterclass. Now, it's something very unique to us, as in, if you say 10 years ago, IBS, it's not something we diagnose often. As a primary care practitioner, it's not a diagnosis I put down very often as well. But you see, I feel it's an area we need to improve a lot in. We need to stop giving the knee-jerk response of putting down hyoscine, buscopan, and getting people into intestinal obstruction unnecessarily, all these kind of problems. We can do better now with medicine like today's. So now the importance of today's talk, a lot of mankind's history starts from Egypt. So it's almost the best example I could give. In the past, when you're someone important, perhaps not me, like Dr. Ko, someone of esteemed importance, a pharaoh, perhaps. Now, you would want to be eternalized. And it's one of the important things is to preserve the body. And when you preserve the body, mummification, you've really been to this if you like Brendan Fraser and the Mummy. So when you mummify a body, you remove all the organs through a nice surgical incision and all, and you preserve everything. They do not remove the heart. The heart is kept. Because for them, this is where the soul and the mind is. The heart is of utmost importance, is retained. Everything else, the intestine, all of it, all into a big jar, preserved and kept, and everything is pushed into the tomb. Today, we know better. Today, we know the gut has its own immune system, has its own nervous system. It even has its own citizens. Once in a while, you get a parasite, you got all the microbes, all the intestinal flora, all sorts of things today that we know better. And we need to treat it as such, because this whole thing, it involves our lives and it affects us in other ways. So when our patients today come to us and tell, sakit, angin, this term, angin, it's like the bane of most young doctors' lives. But eventually you come to accept, okay, it means discomfort, the patient is in pain. Is it a surgical abdomen? Do I need to treat it with medicine? How do I go about? And you come to a point where, okay, you know what, this patient keeps coming back. What's going on? And that's where today's talk comes in. So today we have three very distinguished speakers. Before we go to the speaker's profile, I'd actually run through some simple announcements. For those at home especially, do use your headphone and headsets to get the best quality. And if you have any questions later, there's going to be a Q&A box in the Zoom chat. Make sure to type your questions in, and we have staff handling that. And if you have any technical challenges, anything whatsoever, you can just type in the chat box. We have people there to handle that as well. So we'll request your feedback at the end of the webinar. There's a QR code to scan. And don't worry about CPD points. We'll get to those details later at the end. So later, there's something for both doctors and pharmacists. Now, today, besides this welcome address, we have Dr. Ko Chai, who will be speaking on bloating and intestinal pain, followed by Prof. Dr. Lee, speaking on the practical approach in diagnosing and managing IBS, and a low FODMAP diet in managing IBS by Prof. Dr. Hazrin, as well as a panel discussion after that, and some light refreshments to everyone who came today. Now, these are our three speakers today. First off, Dr. Ko Chai is a general practitioner at Polyclinic Kepong Baru. But besides that, this man, he is also the immediate past president of the Malaysia Medical Association. He's also a Manipur alumni president. He's the vice chair of the Confederation of Medical Associations in Asia and Oceania, and the treasurer of the Commonwealth Medical Association. He's also a member of the Malaysian Health White Paper Advisory Council. Now, other than his long credentials, as well, he's very active mentoring students. He's been an active member of the MMA for over 2 decades. And above all else, he stands for safe medicine. So without further ado, actually, I'd like to invite Dr. Ko to the stage to start with a great talk.
Thank you, Dr. Lingesh. Very good afternoon. Okay, what I'm going to touch on is actually something which all of us see very frequently in our general practice, right? I won't be going into too much of details on the diagnosis, management, and all that, because we have got an esteemed speaker after me who will be going much more deeper into that. So first off, the topic today would be bloating and intestinal pain, a common challenge in primary care. And before I can go further, I would like to touch on what is IBS. So I'm sure all of you know what is IBS, right? Anybody? So, Dr. Lingish, what is IBS? Irritable. Just to get the flow going, because I think it's nice to have an interactive session rather than me just talking to you just like that. So anyway, in irritable bowel syndrome, it is a chronic illness characterized by 1, abdominal pain, 2, bloating, and the transit disorder. So the key point to note is it is a chronic. Some people say it is not an illness, just a condition, but whatever it is chronic. And it is a functional bowel disorder whereby the normal function is impaired. And what sort of functions are impaired? One is the movement of the intestines, the sensitivity of the nerves of the intestines, and the way in which the brain controls some of these functions. And the other point to note is that the digestive system looks normal. That means that whatever investigation you do, it is always normal, right? There's no pathology there. So endoscopy, X-ray, blood tests, whatnot, you won't be able to find anything there most of the time. So are you aware of room 4 classification? They have got room 1, room 2, room 3, room 4. I think room 4 was only updated about 6 years back, if I'm not mistaken. I'm not into GI sort of, the diseases and all that, so I'm not too much into it, but from what I can gather, it's about 6 years old, room 4. So in order to use room 4 criteria for IBS, first off, 6 months. Symptoms must be there at least 6 months. Anything shorter than that, we are not supposed to be using room 4 criteria. So if symptoms have started 6 months and way beyond that, then we will look at it. And we would have to look at pain, okay? Recurrent abdominal pain. This is a very crucial point. I think in room 3, they were talking about the discomfort and all that, but they have taken it away. They have thrown it away because they say that discomfort is it's not easy to define it. So they're defining pain now. And the pain must be there for at least 1 day per weekdays in the last 3 months. Meaning that, just say on average per month, you need to have four episodes of pain. So that's a way, the reason why they have written it like that, there's a explanation behind that. But I think for our purpose, you just remember 1 day for every week for the last 3 months. And that is not enough. Number 1 is pain. You must have at least 2 of the following. 1 is related to defecation. Earlier on, I was always of the impression that defecation will give relief, but it's not always so. Why they have got pain here and then related to defecation is that they say that there are some who experiences pain on defecation. The literature on IBS is actually very vast out there. If you were to go and start Googling and going through all the papers, and now of course ChatGPT. Who have tried ChatGPT? If you were to ask for how say you type in IBS and whatnot and all, they have got a lot of answers there. But of course, when you go through all the answers they give you, it all comes back to the same thing. It's just a different way of explanation, but all can always come back to the same thing. And after that, you find that you need to derive your own understanding of what they are trying to tell you, because what you see in ChatGPT is all just quite standard. I was on a radio session, TV session just a couple of weeks back talking about ChatGPT. Everybody was so excited and all that. So, but then if you really go into it deeply and try to see how it can help you, you find that it assists you, but it's not the know-all and answer-all for all that you want to know. You just use it for to help you along the way. I tried to cheat by using that to do today's, draw up today's presentation, and I found that no, I don't think it can do that for me. Maybe I do not know how to use it fully. So anyway, coming to related disfecation, another one would be associated with a change in frequency of stools. The person may have a decreased frequency of stools. What we are saying is about defecation of less than 3 times per week. and they may have increase in frequency of stools more than 3 times per day, right? So all you need to remember is there can be an increase in frequency, there can be a decrease in frequency. And lastly would be the change in appearance of the stool. Have you all seen the Bristol stool chart before? Right, in all the pictures with all the nuggets, right, all the way down to the watery stools and all that. So we're supposed to be using that chart. So number one is there has to be pain should be there, and any two of the other associated with any two of the other 3 conditions which is listed here. So far, that's clear, right? So symptoms that confirm the diagnosis, just to reiterate what I've said just now, abnormal frequency of bowel movement, which can be defined by bowel movement frequency of more than 3 times a day or less than 3 times a week, right? From frequency, increased frequency all the way decreased frequency, and abnormal stool consistency. I think we don't really need to go to Bristol stool scale because all we can get from patient, or sometimes hard stools, sometimes soft stools or deformed stools or whatever. From there, we can make out already that there is an abnormal stool consistency and abnormal stool passage, like straining. They find it very hard to push out and they get pain on pushing out. And then urgency, after they eat something or just by thinking of going on a flight or a long bus journey, they will have some form of urgency and feet. And when they go to defecate, they have got feeling of incomplete evacuation. And then there can be mucus in stools, and of course, bloating or feeling of abdominal distension, like what Dr. Linge said, angin. But angin is very difficult to decipher in our patients. You know why? They can even come and tell you they got angin in the head. So what does it mean? In Chinese, we say tao feng, that means you angin in the head, that means they're mad, So, well, angin is the way in Malaysia, whether you are Chinese, Indian, or Malay, a lot of times they use this term. So the other point to note is symptoms fluctuate over time. Today they will come to tell you that, I've got this constipation problem, this and that. Tomorrow they'll come in with another complaint to say that, each time I sit down when there's a big crowd and then I'm getting ready to, travel and this and that, I feel like I want to go to the toilet. There are different symptoms. So sometimes most of us GPs will think, okay, today you come for constipation, I treat you for constipation. Tomorrow you come and tell me that you feel like going to the toilet a few more times and then bloating, then I give you something for wind. So it's most of the time that's how we treat our patients. So 1 year after initial diagnosis, we find that 30 to 45% of patients will have prolonged periods they are symptom-free, potentially in remission. Potentially in remission means they may go for remission or they may not. So anyway, you can say that close to half the patients will have prolonged periods that are symptom-free. They'll be symptom-free for quite some time, then it comes back sometimes, right? And after 10 years, you find that 50 to 70%, there's more than half, will have persistent symptoms. So it is a condition which never really goes away. It doesn't really go away. So it will wane and then it will come back. It will come back, then it will come back and then go off again. And following IBS symptom resolution, 45% will experience other functional GI symptoms. So even if we have resolved their symptoms, they will come back to us with other functional GI symptoms as well. And 2/3 of IBS patients experience functional dyspepsia, 7 times higher than in controls. Confused? I was confused when I was trying to read this and trying to decipher whether I should change the way these sentences are written. What I'm trying to say here is that IBS is not so easily understood, even though we have a criteria there. So, but what we need to know is IBS is, number 1, functional disorder. It is not a disease, but a syndrome, and it is a combination of associated symptoms. It is not life-threatening. We don't have gut, bleeding from a GI tract, and there's a normal-looking gut, as opposed to inflammatory bowel disease, whereby it is an organic disease. Examples are ulcerative colitis, Crohn's disease, and it causes chronic inflammation, can be life-threatening, may cause bleeding in the GIT, and abnormal-looking gut. Now, if it is not life-threatening, why would we want to bother? Like I said, they come to us, we just give some, antispasmodic, they complain angin, just give something for angin, and then send them on the way, they'll be very happy. It's just that it is a prolonged sort of condition, and patients do come back again and again. And each time they come back, we find people coming with depression and all the related psychological stress and all that. That's what we sometimes encounter as well. So it's not easy to manage it. So we can't just say that because it's not life-threatening, we can just leave it alone and treat it symptomatically. So, differential diagnosis. Is IBS a condition by exclusion or diagnosis by exclusion? That means exclude all other conditions, then diagnose it. Or do we diagnose IBS and then later on we look at all the other conditions, which to make sure that patients do not have all the other conditions. So what I'm trying to say is, number one, when you go through all the literature out there, there are some who say that it is a diagnosis by exclusion. That means you need to exclude all the other diseases before you can come to a definite diagnosis that it is IBS. But the thing is about IBS in general practice is that if you were to go through all the exclusions, you find that you'll be over-investigating all the patients. They come to you with angin here, angin there, and all those things, and you start doing all the investigations. And that is, you exclude everything else before you come to this diagnosis. But in primary care, Prof. Lee, who is coming up to us, he may differ with me, or he may agree with me. I do not know. He's the expert. But I would say that in primary care, we need to make a diagnosis and attempt treatment. And along the way, we look at the patient. We must understand the patient who is in front of us and see whether we should go further into investigations based on certain alarm features, which I will go through. So we need to differentiate between bowel habit disorders, IBD, colorectal cancer, celiac disease, colonic diverticulus, polyps, and so on. They're quite a bit. But what we need to look at is age group, 45 and above. We know that when a person touches 45 and above, depending on which literature you're looking at and depending on which disease, which system of body you're looking at, we know that as a person ages, once we touch a certain age, there are certain other things we need to look at. Red flags for gut disorders would be 45. So then if there are blood in stools, because it is IBS, a functional disorder, we do not expect any pathology, so we do not expect to see blood in stools. So there's blood in stools, unintended weight loss, nocturnal symptoms, fever, signs of infection and all that, and abdominal mass, ascites, we suspicious other conditions. Family history of colorectal cancer and presence of anemia. So first thing is, after age of 45, we have to be careful, and then we have to look at all these features, which I think we are all very familiar with. So coming to this bloating and distension, I was thinking that I may not add in this slide, but then looking at it, there are many people who do not understand the difference between bloating and distension. Now in IBS, is it just pure bloating? In the literature, they'll say bloating, bloating, bloating. So you have to differentiate. Bloating is the sensation of angin which they get. Distension is the actual distension which we can detect clinically when we examine the patient. Now, there are patients who the bloating is so much that you get distension as well. I've got patients coming to me, they'll be burping away and complaining of their bloating, a lot of angin, and when you just pull up the t-shirt, you see the whole tummy is swollen. And a young medical officer would panic, straight refer them off to the specialist. But we do see such cases of bloating as well to that extent, right? So bloating is just a feeling of, inflated balloon in the abdomen, feeling of swelling or fullness. And distension is where you physically see the swelling, as there's a distended abdomen. How am I for time? Still okay. Okay, so the reasons for bloating, there's increased gas in the intestine, of course, right, angin. And then there's small intestinal bacterial overgrowth. There's the dysbiosis, sometimes due to the result of taking antibiotics, because you change the intestinal flora when you give antibiotics. And then food intolerance or FODMAPs, which will be touched on by our speaker, another speaker this afternoon. And then there's visceral hypersensitivity, which is frequently seen in IBS. And of course, this is another one which increased curvature of the lumbar region of the spine. I think this is something which we don't really see so much here. So the first few points are the reasons for bloating in IBS. Now, globally, sorry to have to show you all these things because sometimes in the afternoon after the makan, a bit sleepy. So 10 to 20% of adults and adolescents have symptoms consistent with IBS, right? 10 to 20% of adults and adolescents. And it's the most commonly diagnosed GI condition. Approximately 30% of referrals to our specialists actually diagnosed as IBS. And this is an interesting part, second highest cause of work absenteeism after the common cold, right? Of course, apart from people declaring that I'm COVID-19 positive, 7 days automatic leave and all that. So this is second highest cause of work absenteeism. And the sex ratio, 2 females to a male. So we tend to see more females than male. That is globally. Now, I'm not interested in global, whenever they have data from overseas and all that, I would always like to ask, what about our country? If not our country, what about, regional areas, Southeast Asia, or even Asia? So there is actually a lot of studies being done on the Asian population. So they find that the prevalence in the Asian population is 2.9% to 15.6%. Now, you will ask me, why is such a big variance, 2.9 to 15.6? They're talking about whole of Asia, right? So different regions will have different percentages. And they say that in Asia, the prevalence is more or less equal between the men and women. It's not women more than men, it is men and women. But I think maybe in our own practice as well, depending on the population which we are taking care of, urban, suburban, or the racial setup, maybe we may be able to see a bit difference as well. I don't have data to share with you on that. And it appears to be underdiagnosed, especially among Chinese communities. I do not know why that is so. Anyone care to comment on that? Okay. Sorry, no promotion of your branding and all that. Okay. Anyway, it's true. A lot of our patients do take that. Even today, I have a Bangladesh worker who came in, diarrhea for past 3 days, and he told me, I was taking the protein pills for the 3 days, past 3 days, and I didn't get a relief from that. So even foreign workers in Malaysia, they go along that path. So, so more than 50% of patients with initial diagnosis of functional dyspepsia actually had IBS, right? So, meaning to say that the IBS may be underdiagnosed. And 20% of patients referred by GP for endoscopy also found to have IBS. And more than 50% of women who consulted ONG for abdominal pains also had IBS. So I think that that's the reason why today we're talking about IBS, to allow us to recognize that we need to be able to diagnose IBS and not just, say angin and send them off. We need to have a diagnosis because at least we can manage our patients better in the long term. And Asian patients present more frequently with upper abdominal pain as well as bloating. And apart from this, the reasons why they come to us for consultation would be evacuation difficulty, right? And then passage of mucus. Now, passage of mucus, when I was going through the literature and all that, it is most frequently seen over in the Asian population. I do not know why. Maybe if you're interested, you can ask properly why we get more passage of mucus in the Asian population. And then change in stool frequency is only a minor complaint. So most of the complaints from patient would be upper abdominal pain. Pain must always be present. Bloating, evacuation difficulty, and passage of mucus. So not life-threatening. Why do we want to bother about IBS? Because it has got negative impact on quality of life. If you see a person who is suffering very badly from IBS, a person who have not come to grips with the condition which they have, because there are many who actually get used to it, right? Before traveling or before eating certain food, if they know that they're going to have all these sort of problems, they know, they look at, they rather go to eateries which have got a toilet nearby, and then before going on the flights or before doing any journeys and all, they sort of prepare themselves, they get used to it. But we find that there's a big group who really can't manage the symptoms, and they get very depressed, and it affects the quality of life. And it is a chronic medical condition, like I mentioned in the earlier slides. Even though there may be periods of remission, but after 10 years, we still find that more than half still do have symptoms after that. And it is one of the most common reasons for visit to primary care doctors and GI specialists. It impacts on their daily functioning. I'm sure you have many friends, isn't it? The moment you go for any makan with you all, before you can even finish the makan, they say, excuse me, I need to go to the toilet. And then they'll be spending 15, 20 minutes inside there. And most of our bowel movements within 5-10 minutes can come out, but sometimes they'll be straining there, trying to do this, that, incomplete evacuation and all that. So it impacts on daily functioning. Economic burden, unless the product which we are talking about today is very expensive, I think economic burden is still acceptable because general practice in Malaysia is not that expensive. But of course, once they move on, I think Prof. Lee will scold me. Once they move on to secondary treatment and all that, then of course they will spend quite a lot of money. Because many of them will not be satisfied with what GPs tell them, and they want to go for further investigations and all that. And that's where economic burden will really peak and go up. So healthcare costs, economic burden, and self-confidence. It affects their self-confidence. So I don't need to explain further. I'm sure you understand what I've mentioned about quality of life, the chronicity of it, and the self-confidence part of it. So what are our aims? Symptomatic relief is one of it, okay? Part of it is symptomatic relief. And I think most of us have been doing that all the while with different medications. And of course, probably we'll talk to you about the product which, we're going to touch on today. So it is to relieve abdominal pain and discomfort, relieve the distension or bloating, and improve the bowel function. So these are the things we need to look at: how to remove the angin from them, how to resolve their constipation problem, right? Or to reduce the frequency of the need to go to the toilet often, resume the normal lifestyle, and of course, give patients hope. That patient will say, you're just giving me symptomatic treatment. I've been suffering so many years. Some of them really very distressed about it. So we need to give them hope. Okay, challenges. I'm sure all of you would have undergone these challenges during your time when you spent seeing such patients. So vague symptoms. Patients come into you, sometimes they won't be able to tell you clear-cut what symptoms they have, Like angin is of course, we have heard so much about angin, we understand. But not all doctors do understand what is angin, Say, apa angin, mana angin, right? And apart from angin, there are patients who use different terms as well. Huh? So I'm sure for you all who have been seeing all sorts of patients during your GP practice, they have different terms. So sometimes they can be quite vague in how they want to describe themselves. And in Chinese, we got one term called subjit. I don't know whether subjit is, wet, heat, wet, hot, or whatever we call it. So this one, sometimes when they feel the urge to go and defecate, but then they say, it's not diarrhea, I just feel like going. And then sometimes after eating, some discomfort here and there. It's all very vague terms which they use, which you only understand if you have more time spent with such patients. And the variable symptoms, like I said, the symptoms varies with each visit. Same diagnosis. Each time they come to you, it's a different variance in symptoms. So you should not be thrown off guard, because if it is a regular patient, with doctor hopping, doctor shopping, this is where we miss the diagnosis, because you wouldn't know the history, the background of the patient. But if it is your regular patient, you will be able to pick up, right? And then the mental state. Many of them who suffer from IBS do not see a GP until they can't withstand the suffering. And when they do, they may not be in the best of mood, right? So all they want is just immediate relief from you, and you try to diagnose and all that. Sometimes they will be upset with you. So it's not easy. So these are the challenges which we face. In this time, I'm trying to rush and finish on. It's telling me I still got time, Thank you, because I think the next speaker is still on the way, right? Probably. Should be all right, huh? Okay. So that is a challenge for me standing here, trying to adjust the time. So patients demand, like I said just now, they want an immediate diagnosis to be made for them to receive the treatment, which may lead to initial over-investigation. What I said just now earlier on, whether you want to you should investigate when the circumstances calls for it, but do you want to over-investigate, right? So, and be wary of overlapping conditions. Why? IBS can always coexist with other disease conditions, since the possible chronicity of IBS can lead to other disease conditions creeping in unawares. IBS is a chronic condition. You make a diagnosis, you treat the patient. Patient has been there with you for so many years. Then you are caught unawares if there are certain other disease conditions coming in, which may have more or less similar GI symptoms. So you must always be aware. It doesn't mean that once you make the diagnosis, you treat them, it's the same thing throughout, right? And because the symptoms keep on, changing, and also it's a challenge for us actually. And empathy. We are very busy, and these patients sometimes when they come in, they're quite demanding, and because they have been suffering for. I'm not talking about those who have got used to the condition, but there are some who allow that condition to upset them so much that when they come to us, they expect a lengthy explanation from us, and we cannot just tell them, no lah, you won't die from this, don't worry, it's chronic lah, it will be like that. They get upset with us. So we need to have time for them. But the thing is, sometimes it's a challenge, isn't it? So empathy for the patient, what the patient is feeling, put ourselves in their shoes. It's very ideal. I can talk to you about, all this and all, but whether I practice it or not, it's also something which I need to, look at into myself, because it's not easy for us to put ourselves in each and every patient's shoes. But that's what we need to look at. That's our challenge. So now, this is my last slide. So this is a case study of a patient, female, Chinese, 52 years old. The symptoms, first noted many years back, can't recall. This is sometimes what we get from these patients, because they've been suffering from it for so many years. We can't recall. Anxious when traveling on long journeys, as frequently will feel like having bowel movements. They dread having to go on long flights, bus journeys, and all that. Does not like going for prolonged dinner functions, and as she will most likely go to the toilet to clear her bowels due to abdominal pain during the dinner. Complaints of frequent abdominal bloating, and takes laxatives for constipation, on and off. How shall we proceed with this case? No right and wrong answer. It's just a discussion on the case. What did I say just now about the Rome 4 criteria? Number 1, pain. So if you look at this history, the doctor who note down all these things are typical GP lah. Just scribble some points down from patients and all that. Looking at this, I can't even use Rome 4 criteria. Why? There's no pain. But of course, we know that this patient actually did complain of pain, but like what I said, some of us we scribble, we don't record it down properly and all that. So let's assume patient has pain. And is the pain more than 6 months? Well, noted many years back. The symptoms noted many years back, can't recall, so more than 6 months. So pain is there. And just to make it easy, let's go back to the Rome 4 criteria. I think probably we'll talk more on that, but the basis of diagnosis is always the Rome 4 criteria. Don't worry, I'll be ending with this. So the abdominal pain, because patient has been having it for so long that she can't even remember that how long she's been having it. Now, the pain must be at least 1 day per 4 weekdays, meaning that we must elicit a history of at least 4 episodes per month, which we didn't do, or the GP who wrote the thing down did not do in the case study. So 2 points to note: did not ask for pain and did not ask for how frequent it is. Otherwise, we can't go and use the criteria for diagnosis. Then related to defecation, of course, she has got defecation issues, meaning that when she goes and defecate, she feels relief. So 1 point already there for her. Next one, frequency of stools. She complains of frequent constipation. So apart from pain, 2 of the conditions already there. And of course, I did not ask the patient about the change in appearance of stools and all that, because 2 out of 3 is already definitive diagnosis for IBS according to our room 4 criteria. So with that, this is the end of my presentation. Thank you so much.
Okay, thank you. Right now, ladies and gentlemen, if there are any further questions, actually you can type in the Q&A, or if it's really burning hot question, of course, you can type it now, or can raise your hand and ask now, or at the end as well. Are there any questions from the floor at this moment? So we'll save it for later at the end. All right. So now, Prof. Dr. Lee is esteemed professor of medicine and consultant gastroenterologist at USM, gastroenterology, hepatology, and internal medicine, and a senior editor at numerous journals. And I would say publishing more than 300 papers in high impact journals. I mean, that's truly an achievement for most. So it's Outstanding Young Malaysian Award recipient at 2015 as the Top Research Scientist of Malaysia award as well. So he's the current president of the Malaysian Society of Gastroenterology and Hepatology, and past scientific chair of the Asia Pacific Digestive Week 2021, and council member of the Asian Pacific Association of Gastroenterology, council member of College of Physicians, Academy of Medicine Malaysia, and a committee member of numerous international societies, and currently elected as fellow of the Academy of Sciences of Malaysia. Now, Prof. Dr. Lee is literally on the way here, but no worries, we have a backup plan. We do have a video of his presentation for everyone, so we'll start with that as well, but he will be available live for the Q&A. So I believe we can roll on to his video.
Good afternoon to my colleagues and friends, and thank you for the very kind invite from EB Plus for this session today. And my focus would be on the diagnosis and management of irritable bowel syndrome. I'm sure you have heard the excellent lecture from Dr. Koh, and this will allow me to bring my audience today into a more pragmatic and the real life management in my own center. Now, my objective really is to, first of all, introduce some of the key concepts when we are managing patients with IBS, and this will include the biopsychosocial model. How do we assess the severity and also managing the therapeutic expectation of patients? Communication really is key, and very often we do spend a bit more time talking to patients with IBS. And lastly, I would like to introduce this, not a new concept, but rather something a bit more focused within our fraternity, the overlap disorders. And then I will touch on some of the more specific management, including the use of antispasmodics, management of constipation, identification and treatment of small intestinal bacterial overgrowth, management of diarrhea, FODMAP, which is really the topic of the next speaker, which I will not speak on, but I will just briefly mention here, psychological distress, and lastly, conclusion. Now, when we talk about IBS, it's really a product of interactions of genetics and environmental factors, which I call this the early life factors, and how these factors would have changed the gut and the brain physiology. And this result in numerous psychological dysfunctions in terms of cognition, anxiety, and even other emotional behavioral changes, including catastrophizing. And that also lead to alteration in the gut physiology, including changes in the gut permeability, motility, and sensation of the gut. And all of this would lead to symptoms and the outcome, including impairment in the quality of life. When we talk about severity, it can differ depending on whether the gut symptoms dominate over the brain symptoms. And when the peripheral symptoms or the gut symptoms are more than the brain, which constitute about 40%, then these are the patients that tend to be probably older with a more milder manifestation and less impairment in their quality of life. There's also a 35% of patients where the gut and the brain are equally affected, and they have moderate psychological distress as well as moderate gut symptoms. And the more difficult patient will be those who have predominant gut brain manifestation. This constitutes about 1/4 of them. They tend to have more psychological distress, including moderate to severe anxiety and also depression. As I mentioned about therapeutic expectation, this is really the outcome that you are negotiating with your patients. So during my session, I tend to talk to my patient about, right, this condition is not curable, not like where you have an infection, can be treated with antibiotic and you can get well. We need to have a certain expectations, like, do you think 80% will be good enough for you? Or 70% will be good enough for you? Now, many of my patients, they find between 70 to 80% would be what they feel very comfortable. So this is something that you need to talk to the patient during the period of negotiation and also treatment. I did mention that communication is really key, and very often we tend to talk slightly longer with our patients, especially with patients with IBS. And that's also because these patients tend to have seen many doctors before us, and they may have some unmet expectation because we tend to over-investigate. We tend to do a lot of tests, but eventually we told them to be normal. Recently, I've been talking to one of my colleagues, and we've been dealing with a number of these kind of patients. They tend to be more frustrated. And the reason is because they are very anxious despite having many tests done. All doctors told them they are normal. So it's very important is we need to tell them they do have a disorder, a gut-brain interaction problem, and there are treatment available in order for us to help them. And of course, if you are interested in knowing what are the core concepts in the communication, you're more than welcome to look at this publication that I published in the Journal of Royal College of Physicians of Edinburgh. Now, they are increasingly recognized that IBS is not a single entity. It tends to overlap. And in fact, in practice, if you have asked the patients, they will not just have lower GI symptoms, but many of them would have even dyspepsia. So when we ask the various experts or people who have been managing patients with IBS, what proportion of patients with functional dyspepsia overlap with GERD, for example, is you can find the responses as mentioned here, maybe not as common, but when you ask about patients with functional dyspepsia overlapping with IBS, you can see a range of responses, indicating that it's really a prevalent condition in practice. At recognizing that this is such an important disorder, we have published a guideline. We hope that you are able to read this. This is just very hot off the press, but you are able to download this because of the open access. So I would urge you to read this. However, people tend to think that IBS remains a single entity, but therefore we as a group would like to introduce more awareness, and certainly more future work is needed in this area. So let me go to a case study. A real patient, she has already passed away a number of years ago, but still I've been seeing her for a number of years for IBS. She is a 50 years old female housewife, start losing nephropathy and gastroesophageal reflux disease. She complained of weekly upper abdominal pain, tend to be worse after meal, associated with constipation and bloating. The stool is frequently Bristol stool type 1, and Bristol stool scale is something that I always use in my practice, especially when they have changes in their bowel habit. And her symptoms started about 2 years ago. No reflex, physical examination is normal, and a diagnosis of IBS was made. So the question is, as the pain is the dominant symptom in this patient, so how do you manage her pain? Would you consider meberberine, methospasmol, or amitriptyline? So very often in practice, we do start with antispasmodic first, and there are several antispasmodic that we can consider based on the Whitman and Master study, which I will introduce after this. Averine citrate is certainly one of the agents to be considered, and the action is based on a calcium-dependent action by inhibiting the calcium influx, and there's also a selective 5-HT1A antagonism. Meberberine, I think a lot of us would have also used this drug before. It tends to block the voltage-operated sodium channel and inhibition of intracellular calcium accumulation. Now, there have been a number of very effective non-placebo trials, but when you look in detail on the placebo-controlled trials, not all of them reported positive outcome. Another agent would be phenylbarium bromide, a little bit more recent, and it acts by inhibiting calcium influx through the L-type calcium channel. It does to be superior to placebo in improving symptoms based on the number of RCTs that have been published. Now let's go in detail on the Whitman study. In this study, where they assess the efficacy of methospasmol comparing to placebo in IBS, is given about 3 caps a day for 4 weeks. And most importantly is, if you look at this chart here, almost 36.8% of patients would have 80% improvement in their symptoms, and half of them would have 50% improvement. So this is what I meant by therapeutic expectation. So if your patient expected an 80% chance of improving, then about 40% of them would have achieved this outcome. Whereas if some of them are happy with just 60% of improvement, then it's likely with the use of this drug, 50% of them would have achieved this target. One good thing about averine citrate in practice is that it has a very fast action on improving symptoms. Many of my patients would have seen improvement within a week of starting treatment. The master study is a little bit more pragmatic in the sense that most of the time our patients, they may not have symptoms every day. They may have intermittent symptoms every few days. And this is where a study using methospasmol as on-demand strategy, meaning when they are having pain, then you will prescribe a methospasmol. In fact, by this study itself, it has been shown to reduce the severity scores of IBS about 50% mean reduction of the IBS score, which is a questionnaire that we use to measure severity. And likewise, they have a significant improvement in the quality of life scale. So this is something to consider in your practice. In fact, what I do is to, first of all, I will give them a regular dose of metospasmol, say for a month, and once they relieve, they can just have a metospasmol on demand. So the patient was started on metospasmol, but she did have a constipation. So what can you do with the constipation? Do you prescribe lactulose, prucalopride, or biofeedback? Just to mention about laxative or some of the therapeutic agent that we commonly use in managing constipation would include those who can bind water in the stools, including the more well-known osmotic agent like lactulose. But there's also some stool softener which I don't use in practice. They tend to have more problems or side effects. There are also agents that can stimulate peristalsis, or what we call as the stimulant agent, or more recently we call them the prokinetics. Again, if you're interested on some of these agents, how do you prescribe them and the level of evidence, please read my paper that I published in Frontiers in Medicine back in 2014. When it comes to constipation, importantly is if there's alarm features, you think of possible secondary causes to constipation like a colonic cancer, then we need to refer the patient for endoscopy. If the constipation is likely to be primary, we might want to further subtype them in order for us to manage their constipation in a much more effective way. And we might need to consider these tests: colonic transit test, endorectal manometry, and balloon expulsion tests. By doing this, for example, if you have all the tests being normal, then the patient is likely to have a normal transit IBS-C. But if they have an abnormal manometry, abnormal balloon expulsion test, it's likely that the patient have a defecatory disorder, which we need to manage. Likewise, if they have an abnormal manometry and expulsion test, as well as abnormal transit, then this patient will have a defecatory disorder with a slow transit constipation. Without a defecatory disorder, but only abnormal transit study, then you have a slow transit constipation. So patient will have defecatory disorder or defecatory disorder with a slow transit constipation, then they may respond to a therapy which I call as the biofeedback. Now let us move to the patient. In fact, the anorectal manometry indicate a defecatory disorder and a rectal hypersensitivity, but the balloon expulsion test was normal and also the transit time. And she was started on a prucalopride and planned for a biofeedback. But another disturbing symptom would be bloating. So what can you do with this? Do you want to prescribe the metospasmol? Metospasmol itself contains not just the alvarin citrate, but also has simethicone, which we know helps bloating. Antibiotic, or do you consider a probiotic? And the reason why I mentioned antibiotic or probiotic is because there may be a subset of patients with IBS with bloating that has what we call as a small intestinal bacterial overgrowth. And this can be only detected by performing a hydrogen breath testing. And this is a machine that we use in practice to perform the hydrogen breath test. What happened in this patient is that the hydrogen, which is measured in red color, is raised over time. And this is also associated with symptoms which indicate a positive test for SIBO. With that, then you may want to start the patient on antibiotics, including some of the recommendation here, the regimen. But my preferred antibiotic will be rifaximin, given for 2 weeks. Now, after 3 months of treatment, I think she felt significantly better with about 70% of response. But 3 months later, she complained of persistent watery stool with a Bristol stool of 6 or over 7. And she recalled a recent episode of AGE, and a diagnosis of post-infectious IBS was made. Now, is there a role for probiotic? Now, let's talk about post-infectious IBS. In fact, this is a rather prevalent condition. As in Asia, it's about 10%, and in the West, as reported studies or series, is ranged between 4 to 32%. And the risk of IBS increases up to 7-fold after an episode of acute gastroenteritis. Now, way back in 2014, in one of the worst floods in the country involving the East Coast, especially the state of Kelantan, and I myself was also a flood victim where myself and my family, we were trapped for 1 whole week without any water and electricity. After the flood, we did notice an increased number of cases of AGE, acute gastroenteritis. 1/3 of them, any patient that comes in to the hospital, 1/3 would have an acute gastroenteritis. And the prevalence is really higher. We found that almost 17% of them would have IBS, a D, and 12.8% of them would have a mixed type of IBS, giving a cumulative prevalence of almost 30 to 40%. And we found that those who have irritable bowel syndrome tend to have organism originated from the environment or dysbiosis, involving this organism, including the Pseudomonas and Trebsiella. And by giving probiotic, we found that not just the pain improved, but also the mental well-being also improved. And we believe that this is because of restoration in the microbial balance. Now, if you're interested in the use of probiotic for diarrhea, I would recommend you to read this position statement that we have published for the Malaysian Society of Gastroenterology and Hepatology, of which I also authored this. And in statement 12, we have mentioned that probiotics are indicated in irritable bowel syndrome for adults. Of course, the question is, how long do you want to give, and do you want to just give a single type of probiotic, or you want to give multiple strains? Now, based on the meta-analysis published, when in terms of global symptoms, single strain is slightly better than a combined strains, but which particular strain is beneficial is still unknown. And again, if you would like to treat patient with IBS, then about 8 weeks of probiotic would be considered adequate. Anything less than that may not have enough efficacy. Now, in the case study again, she did well on loperamide and a probiotic, but sometimes she still complained of bloating after certain food, especially milk, which can be quite or documented because lactose intolerance can be secondary to an episode of infection. So she was diagnosed with lactose and fructose intolerance following a hydrogen breath test. And what can you do with her intolerance? So this will be the area where Hazrin, the next speaker, will be speaking on, especially the low FODMAP diet. So she was doing well until recently when her husband passed away because of sudden illness, and her bowel symptoms, especially both bloating, got worse. She has difficulty with sleeping and often feels sad with her sudden loss. So how can we help her? Now, psychological distress is really one of the reasons why some patients with IBS will have increase in their symptoms. It exacerbates the hypersensitivity. And certainly studies have also shown a clear association between symptoms and psychological distress in IBS. Now, among the most studied agents, nowadays we call them neuromodulators rather than antidepressants. The reason is that we are using these drugs like tricyclics and SSRI not because for their antidepressant benefit, but we are also using them for the gut benefits. And that's the reason why we call them neuromodulators rather than antidepressants. Now, there are a number of studies before this. They are quite small, heterogeneous. Therefore, the therapeutic efficacy may not be that clear-cut. But more recently, the group from Australia, led by Nicholas Talley. He's a professor of gastroenterology, well known in writing the textbook for physical examination, Talley O'Connor. He and his group did a large-scale randomized control trial comparing amitriptyline with SSRI, and he found that tricyclic certainly is more effective for SSRI in functional dyspepsia, but also in those who have overlap with irritable bowel syndrome. Now, you would like to know more about gut-brain disorders, you are more than welcome to visit our website, and this is the link to the website. So we do provide a number of useful information, education, and some of the research that we are currently doing. As a conclusion, the diagnosis of IBS requires attention to the biopsychosocial aspect, managing severity and expectations, communication skills, and as well being aware of presence of overlap disorders. The therapy should be tailored to more bothersome symptoms of pathophysiology, and this includes the role of small intestinal bacterial overgrowth, respiratory disorder, and psychological distress. And in other words, multi-targeted approach and personalized. With that, I'd like to thank you very much for your attention.
Prof. Dr. Lee made it. We managed to kidnap him from the airport. So a big round for Prof. Dr. Lee. So again, any questions you may have and the audience online, just type in the Q&A in the chat and we'll handle it at the end of the session. So let's move on to the next speaker, Prof. Dr. Hazrin. All right. Prof. Dr. Hazri is currently the head of the Center for Population Health in the Department of Social and Preventive Medicine at the University of Malaya. And he's a recipient of numerous grants and rewards. As a trained dietitian, I mean, this is the man for FODMAPs. I mean, this is the man who's popularizing it. So I believe this is the man we should listen to when advocating the diet. So I think due to interest of time, we'll just move on. But he will be available live for the Q&A session via video. So let's go on to his presentation.
Hello everyone, my name is Hazrin and I'm currently the professor and also dietitian from the Center for Population Health at the University of Malaya. And thank you very much to the organizing committee for inviting me to this IBS Masterclass, Closing Gap in Diagnosis and Management of IBS. The task I was being given is actually to talk about low FODMAP diet in managing IBS or irritable bowel syndrome. I'm sure by now most of you are actually experts already in this based on your practices and work, and we know we've been discussing the whole day when it comes to irritable bowel syndrome is in relation to bloating, either gas excessive passage of wind, either you have abdominal discomfort, diarrhea, constipation, so on and so forth. But normally what will happen is the foods that we consume and potentially some of the fiber that we ate earlier on, or maybe you have heard about what we call it as FODMAPs that cannot be in a way digested and at the small intestine and reach to the large intestine. And because there's a higher osmolarity, there's a lot of delivery of water through the bowel, and that leads to your diarrhea, and as well as at the large intestine, the bacteria or the gut microbiome produce more gas, and that leads to bloating, distension, abdominal pain, and few others. As we know, the clinical management of IBS encompasses from dietary and lifestyle advice, pharmacological therapy, which most of you actually have been given to your patients, psychological intervention. Sometimes these patients is actually all stress, and at the same time, there's a lot of avenues of research looking into the brain-gut connection or brain-gut discussion, complementary and alternative medicine. But of course, sometimes previously using the NICE guideline, they also occurs to give what we call emergence of any red flag symptoms during the management of the IBS patient. So if you look into this NICE guidelines back then in 2015, it's not surprising. They are actually encouraging if the patient comes with certain symptoms, it should following the general lifestyle I mentioned, such as cut down their coffee they are taking a lot, but also include single food avoidance and exclusion diets, for example low FODMAPs, and should be given by the expert. And in here, I mean when I'm talking here, it's actually from the team, from gastroenterologists up until your dietitians there. And we know before we start with the low FODMAPs, these are the general advice should be given, such as having regular meals, avoid missing meals. We monitor in terms of the fluid, restrict tea and coffee as I mentioned to you earlier on. Of course, alcohol intake that needs to be reduced, and is also helping if you actually limit certain type of high fiber. This is a general advice being given, as well as some resistant starch. And we know nowadays there's a lot of things we are talking about personalized medicine or personalized nutrition, but this is not something new. It should be from the diet aspect needs to be personalized to begin with. So in a diagnostic and management pathway of irritable bowel syndrome, I'm sure most of you have been doing a lot with the breath hydrogen test with your patients with suspected to having IBS, and it makes it more objectively management easier for and for your dietitians to actually give advice what sort of restriction from fructose, galacto-oligosaccharides and mannitol. But even though if you don't have the breath testings, and I'm sure you know it's actually part of the symptoms irritable bowel syndrome, you can actually start it, but you have to make sure you have a team member of the dietitian to monitor during the restriction and also the re-challenge, because most of the times when we are restricting food, have to bear in mind we are also restricting certain micronutrients. What are the foods in FODMAP? So we learned about FODMAPs just now in a way that's actually with the fructose, oligosaccharides, disaccharides, monosaccharides, and then your polyols. But when it comes to fructose, restrict if you have fructose malabsorptions. Certain vegetables that is actually, especially like asparagus, artichokes, and certain fruits. Some of your patients might actually have a lot of apples, dried fruit. This is coming to Ramadan season. How many of the dates that they can actually take? Drinks and sugars, apple juice, alcohol, most likely to actually cut down in terms of the wines and ciders, because alcohol is an irritant to the gut, and in a way it actually restricts sticky wine, because if you're having fructose malabsorption. Food is also high in FODMAPs, which also includes with lactose. And not everybody with having lactose intolerance, because when we are doing cut down of FODMAPs and reintroducing, what is important to actually really look what are the things that we're going to restrict and how we're going to introduce and how much they can tolerate. So it's a process. So when you're actually looking for the milk and yogurt, these are the things that you have to cut down. Either it's regular or low-fat yogurt, what we are talking about in terms of the lactose. But bear in mind, when it comes to high FODMAP, it doesn't mean it's a dairy-free diet. But if you have what we call it, if you have lactose intolerance, please actually try to see for some of the lactose-free version. Okay. Food that is also containing sugar polyols. This can also be certain from your fruits, of your apples, apricots just now, but also with artificial sweeteners. Maybe when we are having chewing gum that contains, have this chewing gum is actually low in calorie, but you are looking at it, it contains sorbitol or mannitol. sometimes when you're consuming quite a few in combination with all the other food that contains FODMAPs, what will happen is actually you are going to be taking more than the threshold. The threshold normally we look into not more than as an overall 10 grams of the FODMAPs that you're consuming, which we'll be discussing later. In addition to that, the food that contain polyols just now can also occur or have in certain vegetables. Your cauliflower, your mushrooms. Some people love their shiitake mushrooms. There you go. Some of your patients actually can't even take shiitake mushrooms. Fruit with your watermelon. Sometimes they really enjoy their watermelon juice. Makes them go to toilet. Sometimes severity might not be that worse that you come across with. Maybe they having 3 diarrhea, 3 episodes and things like that. But in certain patients, you might come across them having about 10 to 15 times of diarrhea per day. Foods that contain fructans or galacto-oligosaccharides also should be restricted, and this including with your chickpeas, lentils, and sometimes when you're having spring onion, in a way your daun bawang is actually the white part that you need to actually cut down, or even the onion powders. I know it is tricky, but we have come across with quite a number of patients that are doing quite well. And in addition to that, certain breads and cereals that contain with barley or wheat as the major ingredient should be considered to cut down. Drinks and supplements such as chicory, or you're having any drinks that contains with fructooligosaccharides or FOS, normally with inulin that we continuously talk about to increase your healthy gut microbiome, should be cut down during the restriction period as well, which I'm going to discuss later. Certain nuts, including cashews, pistachio, and even though your rambutan, if you're going to have it, you have to have it less than 4 or equivalent to 4 actually. But the thing is, when it comes to rambutan season, it's very difficult to actually count our rambutan that we are consuming. But one thing good about this IBS diet and FODMAPs is not just about what to cut down, but it's also good to talk about what the patients can have. And this is what patients normally would love to comply with, because most of the times we're just talking about not having this, not having that, not having this. But what is important is actually what can we offer? What can you take? And this includes certain vegetables from alfalfa bamboo, your fruits, your grapes, some banana, guava, and sometimes if you actually herbs and spices you want to use, these are the certain herbs and spices you can use. And even though you want to have certain processed fruits that is dried, like a banana dried, not more than certain numbers. All right, and your dairy, your hard cheese is fine to actually have it. Have tea, have hot beverages like tea, drinking chocolate powder. These things will be fine as well. And in fact, if you want to actually have nuts that you like, you can actually have pecan walnuts or also macadamia. Why we actually encourage this? You need to monitor the symptoms, whether it's well controlled, for between 2 to 6 weeks. And in fact, if you want to know more, King's College London or Monash University actually have their own apps, and you can have a look and you can download what are the foods, the core food. Of course, there are certain limitations with some of those Asian foods. And this is where I'm going to highlight whether this can be applied to Asian setups. In a way, is actually yes, because certain major high FODMAP foods also come from onion, garlic, shallots, and this is come from our review as well. And you can have a look. The red bar basically are the food that high in FODMAPs that we have to cut down. And we look into rice noodles, rice basmati. Those foods are actually low in FODMAPs. And here are some of the condiments that quite you actually not just condiments. This is actually your split peas, your mushrooms. Those are the high, but you can actually have from your broccoli and your bok choy, your okra, which is low in FODMAPs content. With your condiments that you're using, wasabi powder definitely, because it's actually from what we call it very high, can be from soybean as well. But you look into certain like pandan leaves, and your tamarind paste is actually quite low in FODMAPs, and you can use it. So these are the things that's good about FODMAPs. During the restriction time, they can encourage the what we call it the food that is in category low in FODMAPs. And we have done basically in Malaysia, when we look into it, where the patient can comply, pretty much work by our team before it's actually have shown they can comply for about, they can comply for about 2 weeks. What is the current evidence? Looking into the efficacy of low FODMAP diet in irritable bowel syndrome, looking from systematic review and network meta-analysis, this is a fantastic work looking from a series of randomized controlled trial that has been done. This is led by Alexander Ford group together with Heidi and also Christopher Black, whether how efficacious this what we call it diet to begin with. If you look into it, low FODMAP diet is always be the number one in terms of achieving or what we call it an improvement in global IBS symptoms. Okay, so there is also look into that's one, and when they when they actually compare with the British Dietetic Association NICE dietary advice or SHAM dietary advice, is still superior in terms of improvement global IBS symptoms, in terms of looking at improving for the pain severity, and also looking at these are the three things that they are looking at. A low FODMAP diet was ranked first for efficacy across all endpoints studied compared to alternatives interventions, including by the British Dietetic Association or NICE guideline dietary advice for people having IBS. That's the first thing. You can have a look in detail. It's a nice systematic review has been done by that group. A low FODMAP diet was significantly more efficacious than habitual diet for global IBS symptoms and significantly more efficacious from the other dietary advice that have been given. But nevertheless, BDA or NICE dietary advice was not superior to any of other interventions from their analysis. Have read through that paper, and when we read into this paper, we start to query ourselves: such diet, is it really work in what we call it in Asian setup? I think by now there's a lot of studies been also done. They have tested either what we call it in other Asian countries, including in Malaysia. So this is a study basically, I'm sure there are a few other studies ongoing, but this is a study completed by a multi-center study from the University of Malaya, University of Science Malaysia, and also UKM, just to look into when we are giving FODMAPs to these multi-ethnic patients, whether it's going to make any improvement or not. And this is quite interesting. And if you have further questions, Professor Yong Ye, as one of the speakers, is part of our team here for this study, so he'll be able to answer if you have any questions, what's the recent findings. But nevertheless, just a very quick glance, this is how it looks like for patients who are complying really well when with the low FODMAPs, your readings, your breath values is actually getting better. If you are not actually complying well, the reduction is not that great. And this is an overall when we talk about whether with the variation in multi-ethnic population, will they actually affect their gut microbiome? Definitely, because the food that you're going to consume will end up in your gut. And final completed with this recruitment from 3 centers is about 34 and encompasses of several ethnicity, Malay, Chinese, and also Indian. So watch out for these papers. For this particular paper that should be released quite soon. As I mentioned to you, team members, quite a few, and Professor Lee is actually there as well. So prior to actually make when we discuss whether the patients wanted to follow the protocol, I think the most important thing we have to discuss with our patient, it should be a shared decision making, that we have to tell the patient how this is going to benefit rather than we instruct them what they should do. And then the other thing is also it's very crucial to have multidisciplinary approach. And I'm sure with some of the larger hospitals, you will have your dietitians involved. And definitely with teaching hospitals, you will have them on board. So when we talk about low FODMAP, these are the phases of a FODMAP diet. I mentioned to you earlier on, if you look into the low FODMAP, it should be, this is the first phase. under supervision of dietitian between 2 to 6 weeks. So you cut down those are the high FODMAP food, but you swap, as I mentioned to you, the one that you give as an alternative low in FODMAP, so that you can actually make it possible for the patients who like to eat fruits, but what sort of fruits they can have. And then after completed between 2 to 6 weeks, we'll see if it's actually getting better. We go and re-challenge phase. And these are the steps for the re-challenge phase. It should be also about 6 to 8 weeks. And then if they are not doing well, we need to actually extend a little bit about the low FODMAP phase. Okay. And then once they are doing well, essentially in the re-challenge phase, such as we're asking them to start increasing, if they want to start to take milk, how much they can take. If let's say they want to start to take a bread, how much they can take. And this period needs to be monitored as well. And then after complete with the re-challenge first, there's another phase which we call is adapted FODMAP diet phase. And you can actually look into it, how they can put back some of the food that they like that contains high in FODMAPs. But bear in mind, there are some patients who decided to continue with a low FODMAP foods because they said why they need to suffer even what they had suffered before. So it is quite individual, and then it's good that you have, as I said to you earlier on, shared decision making and make what is the best for the patients themselves. And how to start? Generally is recommended between 2 to 6 weeks. And I mentioned about the paper we've done before with Wong. Basically in Malaysia is adaptable, and you can see the difference between about 2 weeks if patients comply with low FODMAPs is actually working, but then the steps needs to continue low FODMAPs, re-challenge, and then adaptation phase. So there's about 3 phases, and altogether will take about a good 3 months to actually really see. Individuals should then be reviewed by dietitian on which foods that how much they can be reintroduced. That is what I mentioned. Maybe they can have a glass of milk or half glass of milk, 2 slices of bread as an overall towards the end, so that they know how much they can actually take. And how much is too much? Basically, some foods contain high FODMAPs even if the portion size is small, so they have to be careful. And then, for example, there are certain foods that I mentioned to you, they having green, basically you can have as much as possible, but when it's amber or red, that you have to cut down and restrict the amount. And milk that is suitable, if I mentioned to you just now, if you are having a lactose intolerance, not so much a lactose intolerance, but you want to cut down the lactose, you can actually having from the lactose-free cow's milk that is also available in Malaysia, but it's certain brand, and then your soy milk, almond milk, and few others. And common question people will ask, is it possible this should we do 3 consecutive days or alternative? The simple answer is actually you can do it either, and it's best to choose the one that suits you best. And normally for me, I normally will have 1 day challenge and then the next day is off, just to have a look at what's the overall that they can comply. And thanks for your attention, and looking forward for the other session Q&A. Thank you very much.
Thank you to Prof. Dr. Hazrin. I believe he's available online. So can we invite the speakers to the stage for the Q&A session? I can. All right.
Hazrin, how are you? Are you here? Yeah.
Yeah, I'm here. I'm good. Thank you.
Yeah. I think people are very relieved when they see durian as a low FODMAP and only rambutan. I'm just
As long as the patient is actually don't have much of diabetes afterwards, because you know there's nothing that one diet that fits everything.
All right. So before I go to the questions online from the floor, to those who have taken trouble to come all the way here, are there any burning questions for our speakers today? Can you just raise your hand? Okay, while you think about it. Okay. So first question from Dr. Cha. So IBS should be suspected if symptoms persist more than 3 months or more than 6 months. Because abdominal pain should be there at least 3 months. I believe, Dr. Lee?
What corrected the Rome 4 says is that there must be symptoms which is 6 months and above. Then after which we will look into the pain which is persisting within 3 months.
Maybe I can add to the call, which is absolutely correct, meaning that most of these patients, they will have their onset of symptoms more than 6 months. That's what Rome says. And for the past 3 months, the symptoms are getting more troublesome. The thing is, if you look at the symptoms, it's based on frequency, meaning that, are you having the symptom daily or are you having the symptom weekly and so on? That's how we decide on the criteria, the diagnostic criteria for Rome.
Just to remind that, it's written as 1 episode per weekday. Now, from what I read, there some who says that in general, at least four per month instead of 1 for every 7 days. You can have a look at 4 per month.
Yeah, in practice, of course, we don't have to absolutely follow, the Rome criteria. Many of these patients, when they come to you, they are obviously needing help, and the Rome criteria is therefore as a guide. In fact, many of my symptoms, many of my patients, when they come to me, they are already having very troublesome symptoms.
Thank you, Prof. All right, this one's pretty interesting. Hi, doctor. Is isolated high-strength unit of one single probiotic better or a combination of several different ones provide better relief? I think what they're saying is are products that perhaps things like Scalpro, are they beneficial, and is it beneficial to have one high-dose CFU, one type, or multiple probiotic components?
Yeah, I guess many people are very interested in probiotics. And this question always comes not just from doctors, but also from patients. And the reason is we can see probiotic on the shelf everywhere, on advertisement and so on. And some of them, we don't know. Very different from one to another in terms of doses. Some have a lot of strains, some only one. And most people would think that the higher the dose, the more strains are better. I think that is a general belief out there. What I can say is this is not correct. We need to determine what exactly have been studied. Right. Now, many of the probiotic out there, they don't have any proper clinical studies. So it's not possible to determine whether or not they are effective in treating a certain disease. Also, if you look at studies, not higher doses mean better. There are certain studies where even the mid-range doses would be more effective than higher dose or even lower dose. And likewise, I think I've shown in my talk, for certain diseases, single strain probiotic might be better, at least single or double. Too many strains, imagine that if you buy a probiotic with so many strains, they're actually eating the same food in that small little package. The probiotics are live, right? Now, if you find it on the shelf, the longer the probiotic on the shelf, the chance that you're going to find is all dead probiotics. And ideally, probiotics should be kept cold chain, meaning that, refrigerated for a longer shelf life. And that's a problem because by the time when you buy a probiotic on the shelf, people don't look at the shelf life. When was it manufactured? The closer to the manufacture date is probably better compared to when you buy like 1 or 2 years on the shelf, for example. If you look at the package, right, probiotics, they often pack together with say the inulin or other kind of prebiotic, which is the food for the probiotic itself. So the longer on the shelf, the probiotic are likely to finish off the food. More bacteria are there, they are likely to finish off the food in your package, right? Everyone is fighting for it. So you just have to imagine like that you understand that, yeah, the more doesn't mean better. Okay.
Thank you, Prof. There's another question here. Can you reiterate the antibiotic types to give to patients with IBS and what the indications of giving antibiotic? Because I believe in the sample patient earlier.
Right. So I can add. I can start first, and maybe the doctor can add to it. Now, in my practice, by the time patient come to me with bloating, they might have tried a lot of things. It doesn't work, and when they come to me, I have to, in a way, think about possibility of reason for the bloating. And one of the reason is small intestinal bacterial overgrowth, which can be rather common in patients with irritable bowel. Now, in IBS, if you have small intestinal bacterial overgrowth, you will produce gas. And that gas, in most patients, maybe I go through it. In normal people who have no IBS. But if you have IBS, even small amount of gas, you can feel it because you have what we call as hypersensitivity. Right? And this patient with IBS, even though they may not have a lot of bacterial overgrowth, you have seen in studies that even if they have, all right, so sorry, okay. Now, even if they have a very small amount of bacterial overgrowth, it's enough to cause them symptoms. And in this patient, once we detected, if we were to treat them with antibiotics, you can find them, their symptoms are much better. Right? That has been shown in numerous studies.
In practice, we will go and treat with antibiotics.
Yeah, so in our practice, actually what we do is to do a hydrogen breath testing. We don't start the patient straight away with antibiotics. Ideally is we should confirm the diagnosis of small intestinal bacterial overgrowth before we start antibiotics.
Right. Thank you, Prof. It just because it came it seemed to run along the lines of the triple therapy for H. pylori, and I saw the regime. It felt like that, but true, as GPs, we do hesitate. A good practice is you don't jump onto it. Even for infective gastroenteritis, you rather be confirmed by stool testing and all that. But good to learn. All right, there's another interesting question. How do you manage post-radiotherapy proctitis, for example, for CA prostate? So is there a role for meteospasmia or equivalents in these patients, post-radiotherapy proctitis?
Right, for proctitis, it's obviously inflammatory, and any inflammation may potentially result in symptoms. It could be diarrhea, and even some of them may have pain. Now, the pain itself may be a direct effect of inflammation, or the pain may be a result of hypersensitivity, or even the patient may have a pre-existing IBS that somewhat exacerbated or aggravated from the radiotherapy proctitis. Now, if you have, in that sense, if the symptoms are typical of IBS, then yes, the pain, if it has a what I call as a spastic component, then an antispasmodic like meteospasmol will certainly help. And the other question was whether a probiotic will help. Right?
Yes.
Yeah. A probiotic has also been shown to be helpful in even in, for example, inflammatory bowel disease, patient with IBD with a proctitis. In radiotherapy, post-radiotherapy proctitis, titers that have been shown some benefits, but you have to think about which particular probiotics to use, not just any probiotics will work. Because if you say, oh yeah, probably say is working, but you need to find out or know what exactly the probiotics are actually working. Not all probiotics.
That's an interesting one. Now, when it comes to things like meteospasm, we would normally prescribe it, say 2 tablets, 2 capsules 3 times a day. Can it be taken on demand, PRN? When there's pain, can the patient take as much as he likes?
Yeah, in fact, this question is very, very important in practice. It actually in the slide also the master study, the study where describe the on demand therapy. Certainly find a benefit. Now, initially, of course, when the patient comes to you having daily symptoms, you want to control the symptoms fast. And that's when you need to give particular like 3 times a day. And by doing that, you can effectively even have a good control even after that. Benefit by keeping the meteospasm. And once you control the pain, then you can actually
Yes, I do agree with you because in private practice, I think it's always a lot of times on demand. And I think the patient sometimes end up knowing when to take and when not to take as compared to our directions given to them.
For clarity for the online audience, because only one of the mics is linked to Zoom, we'll focus on one magic mic. All right. So we've got a whole lot of interesting questions actually. Sorry if we didn't get to all of them. Now someone is asking, how do I interpret the hydrogen breath test? To my understanding, I mean, we do urea breath test and we get a report, but when we do a hydrogen breath test, I mean, I'm thinking this is something we refer to the gastroenterologist to take care of it. But is there maybe a report, a level understanding that from the primary care or the pharmacist may want to know?
Right. So during the hydrogen breath testing, we are measuring 2 gases. One is hydrogen and the other one is methane. Now, if you have a small intestinal bacterial overgrowth, you expect the hydrogen to rise. Well, it can, because for hydrogen breath testing, we tend to do the test over 2 hours. And we'll collect the breath from patients at a regular interval, say 15 to 30 minutes. Now, in order to make a diagnosis, we need to have a level. What was the appropriate hydrogen level and what will be the appropriate methane level? So that will be, in a way, based on the existing literature where we study comparing a gold standard where we do a culture from the small intestine, where we look at the level of the bacteria and we correlate that with the level of the hydrogen that we measure. Now we have certain cutoff, probably at this moment, it's very difficult to mention, but if anyone who is interested, I can certainly write to us and we can certainly share with you the paper and so on what will be considered the appropriate cutoff level.
There's a question from Mr. James. You mentioned FODMAP apps just now. May I know which app you mentioned? I think it's the Monash something like that. Yes, I think this question is for Prof. Dr. Hazrin. I don't know, sorry. There's an app you recommended. Perhaps you could detail it.
Yeah, I think the one that's actually that is available that you have to download will be the Monash app. That is available. That is one, and King's College London as well. They do actually have. But how to look into it is basically from these apps. They have lists of foods from the vegetables and everything that where you see what is high and what is low. When you look into the Mr. Google, basically they will give you everything. You have to be careful because I would say about 95% of them out there can be rubbish. So the FODMAPs apps that you can rely on is because the food that they before they put into the content, they need to really analyze in a proper lab. So yes, I can just answer about the Monash as well as King's College London. Is it clear? Sorry, when I should ask before, you can hear or not?
Yeah, totally. It is audible and clear. Thank you.
You're welcome.
There's another question here on, I think the use of amitriptyline. Because interestingly, I mean, we do find more people using amitriptyline for migraine and headaches. Now, in terms of using amitriptyline for IBS, would the treatment cause worsening of the constipation?
So this is a fantastic question. We know that all these drugs are not without side effects. And as a prescriber, as a doctor, we need to know what are the symptoms that may increase or decrease following the use of these neuromodulators. You must understand that tricyclic like amitriptyline is a dirty drug. What I mean by dirty drug is that it acts on many receptors. And by acting on many receptors, although it may carry benefit, say, in controlling symptoms in patients with IBS, but it may worsen certain symptoms, for example, constipation. So if you have a patient with IBS with constipation, then you probably should not use amitriptyline to control pain. Now, if you use a drug like amitriptyline, the main reason for using it is to control pain that is refractory. For example, if you use metospasmol, it doesn't have achieved the benefit that you want in controlling symptoms, then you can consider adding a low dose amitriptyline, but don't use it if you have patient with IBS constipation. Right.
Thank you, Prof. All right. There's another question. Can we prescribe metospasmol to patients with dyspepsia or GERD?
I think it can be used because this is more for antispasmodic, so it should be no problem there.
Yep. Now, yes, I mean, in fact, I think I did mention in my talk, we are more commonly in practice to find what we term as overlap, meaning that patients with dyspepsia, they may even have lower GI symptoms. This is what we call as overlap. Both dyspepsia, which is the upper GI symptoms, but the patient also have a lower GI symptoms together. It's actually very common. If you ask them more or really dig deeper into their symptoms, or even ask them their Bristol stool scale. The easiest is like in your practice, right? Always show your patient what is your stool. I always ask that question. I will always bring up my Bristol stool chart on my computer screen and ask, so what's your stool like? And that itself will unravel what are the other lower GI symptoms that your patient may experience, because they sometimes won't volunteer that information. So it's very common to have overlap. Now, if you have patient with overlap with IBS, then yes, you can. If you prescribe a metospasmol, then yes, you hit it right. You would have relief from pain. In fact, a lot of the time is when you have patient with dyspepsia, the first thing is you prescribe a proton pump inhibitor or something to control the acid. That is the most common thing to do by many doctors. Now, if they respond, fine. But if they don't respond, then you need to think, could there be another functional disorder that may actually coexist. In fact, it's very common. If you look at papers, it's very common. And when you add a meteospasmal and then magically the patient, improve, then you clinch your diagnosis.
Thank you, Prof. I think we end on one interesting question. Clinical hypnotherapy has been well documented in management of IBS. Any comments on this? I'll just link it up to another question, because I'm also curious, because we are hesitant to put the words IBS down, because at the GP level we have not definitively excluded everything. So it links to that. How do we proceed with that?
We have seen that the psychosocial aspect of IBS is always there. It's always present there. And hypnotherapy, of course, is not that easy. I mean, we have got quite a lot of our GPs who undergo the course and all that. It's not a so-called miracle sort of thing. But I think it does help. It does help in certain patients, especially those who have not come to grips, like what I said, they can't accept because IBS is a chronic disorder. So there are some who manage to accept our explanation and all, but there are some you need to really sort of tune them up. So I think hypnotherapy will work well there.
All right, thank you. So just, sorry, Prof.
Yeah, I just like to echo what Dr. Lingesh has mentioned. I think there's some reluctance from the general practitioner side to make a diagnosis of irritable bowel syndrome or, in fact, other functional GI disorders. And the reason is we have this paradigm being taught from medical school that every patient that comes to your clinic seeking help must have an organic disease. And that paradigm has not changed. So that's why I think a lot of general practitioners or many of my colleagues have problem in diagnosing irritable bowel syndrome or even functional dyspepsia. But actually what they really have is that. So do think about it, when you see a patient in your practice.
So Prof, which was what I mentioned earlier on, is IBS a diagnosis by exclusion?
I think that's a fantastic question, because in certain patients, I think the paradigm is that a lot of people think you can only diagnose IBS after you have exclude everything possible. But is that really possible? Right? In medicine, it's not possible, because some of the disease will only manifest later on. And it's very difficult to do an exhaustive list of investigation, because the patient have to pay for it. And they're very frustrated when you told them you are normal. Nothing is there. After they have paid so much of money to do all the tests, and the final diagnosis tell them that, oh, you are normal, everything all normal. But if you give them a diagnosis of irritable bowel syndrome, based on the diagnostic criteria, he fits the criteria, there's nothing wrong to make a diagnosis at that point of time. Now, if later on the disease change or the new symptoms arise, or there are new findings, and you do a test to confirm that particular disease, you can change. It doesn't mean that the patient must stick with IBS all the life, isn't it? Yeah, something to ponder and think about.
Thank you, Prof. I believe, okay, sorry, Prof. Azrin?
Sorry, I have to go, but I just noticed few questions that may be relevant to me. There's one question asking about the Monash FODMAP app without dietitian advice. Normally, we will direct them to that particular app after we have given them the advice so that you can monitor. But bear in mind, nowadays things you cannot control. Some patients who are coming already downloaded the app. So what is important as healthcare professionals, we need to be aware, what are the apps, is it reliable or not? I hope I answer one of the question. And then there are a few other things as well. When you're looking from the role of the diet part, even though if they're having constipation, as Yong Ye mentioned earlier on, look into your Bristol stool chart. I normally show that as well, if those who are here from the dietitians or the GP, because sometimes when they say they have constipation, constipation, double check whether they are actually on certain type of diet. And if they are on keto diet, their carbohydrate intake is low. And once your carbohydrate intake is low, definitely your fiber intake is low. So I don't normally straight away start with FODMAPs. I will look into the general first, then only I will go into the FODMAPs. I hope that makes clearer, because individual patients, they come to us, they have already certain types of diet they might actually following, especially those who are more highly educated that coming to see us. So I hope that summarized as an overall, it needs to be it's not just one thing to feed it everything, but today's session is more I'm sharing about just FODMAPs, but I can see all other questions is also interrelated. I hope that is clear from your side. You can hear that, Dr. Lingesh?
Yes. Thank you so much.
And
Actually, I have a lot more questions, but I believe the app will answer some of them, because I saw the long list of food and I was a bit concerned.
Oh, right. Okay, I can briefly tell about the app. Basically, don't worry. Even though if you don't have the app, the common foods that should be excluded during the period of low FODMAPs is the common foods such as your onions and everything. What they need to do is some modifications on how to do it. It is not easy, especially if you have patients who have IBS, but then they just post chemo and then they're asking so many questions. We have to deal one thing at a time. So normally we will do it what we call it, look into what are the things that are possible for them to exclude. And I will go for the food that is high in FODMAPs first. I know the list is long, and that's why if you're working as a team, you can refer to others so that burden your workload. That would be another suggestion for me. But if you are on your own, take some tips such as remove it, some of those high in FODMAPs, whether it's improving or not. That is my take-home messages. The list is long. I totally agree, but we do it as traffic light system. What you cannot take, what you can take during re-challenge, and what you should be taking during the low FODMAPs. Okay? All right.
Thank you, Prof. Hazrin. Thank you.
You're welcome. Okay, everybody. Thank you very much for your time. Yong Ye, I will see you again. Hope more for us and another doctor there. I can't recall, but nice meeting you guys.
Thank you, Hazrin.
You're welcome.
I believe, are there maybe one question from the floor, if anyone? If not, I think we can call it a day. I think we've all elevated our practice today, definitely. And I believe there's a role for meteospasmal every day in a GP practice, and it will be commonplace. So definitely consider. Are there any questions? If not, I believe it's been a great presentation today, Dr. Koh, Prof. Lee, Prof. Hazrin. So a round of applause for the speakers, and there's refreshments after this. Now, for the doctors, it's pretty easy because you registered, and EP Plus staff is going to handle your CPD points. For the pharmacists, if so choose, there's actually I think we have projected after this. There's some details should you need the points for the pharmacists. All right, so Jom Akan, let's do it. Thank you everyone.
Thank you.
Just over there. Guys, can come on stage for a quick photo. It's great for Facebook. I think the EP Plus staff as well. Please. Oh, okay. Oh, okay. Come, I got two more people. Shy people, come.